Thanks for being here this morning. Appreciate it. I know it's early on the last day, so thank you so much. I'm going to talk a little bit about the results and recommendations from the health equity assessment that we did with CalFresh Healthy Living in 2022. So first, to introduce myself, I'm Maggie Wilkin. I'm the Director of Research and Evaluation for the Center for Wellness and Nutrition, which is a program of the Public Health Institute. So this is a little bit of background on the health equity assessment. As you know, racial equity is a national priority of the Biden presidential administration. And USDA's FNS has created equity as one of their pillars. Here you can see how California has incorporated equity into their principles, priorities, goals, and objectives, with the objective of by 2026, direct education recipients will be at least 75% of the SNAP-Ed eligible population proportion. So we conducted this assessment with CalFresh Healthy Living with the goal of identifying and describing current practices and areas for improvement for incorporating racial and health equity practices in CalFresh Healthy Living, programming, planning, and evaluation. Our assessment included a comprehensive literature review, spatial analysis using GIS data, geographic data, online surveys for state and local implementing agency staff, which some of you might have participated in. We had a health equity roundtable discussion at last year's pre-forum session that we incorporated those results as well. And finally, we did some key informant interviews, which are in-depth guided one-on-one conversations with local and state leaders that are incorporating equity into their nutrition or public health programming in California. Oh, sorry, I didn't switch the slide. Okay, so I'm just going to give a brief summary of the findings from each section so that I can focus on the overarching themes and recommendations. Our full report will be released very shortly. We are in the final editing stages. So for the literature review, we did a systematic review based on these guiding principles from the Bread for the World Institute's recommendations for applying racial equity lens to federal nutrition programs. So we did keyword searches based on these 6 principles and organized our literature review in these categories. This is an example of one of the GIS maps. We did our mapping at the census tract. Oh. Sorry, I'm moving it here. This is an example of one of our maps. You can actually go to that link and you will see a story map that has all of the maps that we did. We overlaid PSE sites with the SNAP-Ed eligible population, the percentage of Latino, Black, Indigenous, or other populations of color from census data. We also looked at low income and low food access census tracts based on the Food Access Research Atlas, and we mapped the Healthy Places Index. As I said, this was based at the census tract level, but LIAs can use these maps to identify high need areas within their counties. We plan to update these maps with 2022 and 23 data. We found from this assessment that overall PSE activities are taking place in or near high need areas. However, there were some gaps, particularly in Central Valley and San Bernardino and Riverside, where there were communities that had very few PSE sites and had a high need for them. Here's some key findings from the local implementing agency survey. There were 110 staff who completed this online survey representing all 4 of the SIAs, and about 18% of all local staff at the time, direct staff, doesn't include subcontractors. This is not representative of all LIA staff, but it did give us a sense of what was going on and what staff members would like to see to help improve equity in their communities. You'll see the common themes across all of these data collection methodologies, and it's probably a lot of things that you're already thinking about yourself. Nearly all were involved in PSE, indirect and direct ed, and partnership or coalition building, with about 2/3 involved in evaluation and 42% in social marketing. The most common ways that the respondents said they were culturally adapting direct ed, for those that are providing direct ed, was translations and culturally appropriate recipes. However, a lot of them said they would like more tailored resources and campaigns for specific groups, and also to see more additional translated materials and curriculum. They also mentioned specific trainings on equity, racism, and cultural humility, tailored technical assistance, and more partnerships with equity and racial justice organizations. For the state implementing agency survey, we had 29 staff, which is about 35% of all SIA staff. Again, it's not representative of all CalFresh Healthy Living or the SIAs. The top 3 challenges or barriers they mentioned for gathering input directly from the community was lack of funding for incentives, lack of staff, and language or cultural barriers. Some of the things that the SIAs mentioned they would like to see to help improve their services were asset-based or strength-based approaches, PSE guidance on tailoring activities for specific groups, additional translated materials, as we heard before, and then a new tailored curricula. Here are some of the findings we had from the Health Equity Roundtable discussions. Participants felt there was a strong need, and we keep hearing this over and over again, for more translated and culturally tailored education and resources. They also felt there was need for better feedback loop between the leadership and the educators. They would also recommended some foundational training and cultural sensitivity and equity. I know are trainings that are available already, but I think people are looking for more in-depth trainings. Equity framework and equity partnerships, and then more community involvement, community engagement. In the key informant interviews, we had 6 interviewees who work primarily in nonprofit and university settings. We organized their findings into 3 main themes: challenges, facilitators and structures to support equity work, and then recommendations and resources. For time, I'll kind of skip through here, but you can see there are some familiar themes that we saw before about centering community, defining and measuring equity, community engagement, equity-centered evaluation are some of the things that were mentioned by the key informant interviews as well. So we summarized our findings. As I said, there were some common themes across the different data collection methodologies, and we organized them into these 4 buckets: the organizational commitment and investment, community engagement, equitable compensation, acknowledging, dismantling, and rebuilding systems of oppression, and inclusive evaluation practices. So these findings really informed our recommendations. So the first area of recommendations was under organizational capacity building. So investing in and developing internal best practices and processes that promote equity. We found in the LIA survey that a lot of organizations either didn't have specific policies related to equity, or their staff members were unaware if they had those policies or not. Also, developing foundational health equity trainings for staff was, again, a lot of trainings are already happening, but a lot of the LIA respondents were interested in more trainings on equity, racism, and cultural humility. And again, the roundtable attendees also mentioned those. Establishing a statewide justice, equity, and diversity and inclusion committee that includes representatives from SIAs, LIAs, and CalFresh Healthy Living populations to help identify and integrate best practices into programming. The other area of recommendations are program and resource development. We saw a lot of conversations about this, about centering community and engaging community members with lived experience through all aspects, including including design, planning, implementation, and evaluation. And also ensuring that community participation is fair and valued by providing fair compensation or reimbursement, consistent with CalFresh Healthy Living guidelines. As we know, FNS funding is restrictive and generally can only compensate for reimbursement for time. However, partnering with other organizations or finding ways to create staff positions for community can provide more flexible funding. Expanding language offerings and cultural adaptations of education materials and curricula. I know that CalFresh Healthy Living is doing a lot of that already, but it seems that that is one area that people would like to see more translations, perhaps in different language offerings that they haven't seen before, and also more cultural adaptations. It's not enough to just translate, but also needs to be, culturally relevant. Expanding co-creating and co-designing culturally tailored campaigns with the community members so that they have more buy-in in the programming. And then finally, we have recommendations related to evaluation practices. So first is to recognize and acknowledge the implicit biases that influence evaluation practice, and invest in mixed methods and systems approaches to collecting and examining data. Understanding these conditions and looking at a widened perspective of data collection that can shift the burden of change from individuals to how the system can better change to support people. Reporting and disaggregating data by race and ethnicity. I think a little bit of this is starting to happen a little bit more often to accurately identify inequities, successes, and better tailor program activities. It might, disaggregated data, however, should be used with caution as an asset-based framework that identifies strengths and clearly versus a deficit-based approach. Using GIS mapping to look where there might be deficits in programming, underserved areas, identify gaps in services can be really helpful. And in rural communities, you can involve the community in sort of doing maybe community mapping, looking at different assets that might be outside of CalFresh Healthy Living. What assets are available in the communities? Again, that could be particularly useful in rural communities. Telling the story of community strengths and change using mixed methods, focusing on more qualitative data collection. Stories can provide context, texture, voice. Case studies are more accessible to engaging multiple audiences, and as stated previously, places less emphasis on individual behavior change and looks at the community overall and the systems to support those community members. And you can, participatory evaluation approaches such as best change interviews and photo voice are also really great options. And then finally, having some measurable and relevant indicators of progress and change is an essential component of the health equity framework. We all want these measures. We're all looking to have something that tells us how we are progressing in, our equity efforts. So I think it's really important to look at what indicators we can use for that, such as using the disaggregated data, doing the GIS mapping, looking at levels and participation of CalFresh Healthy Living programs, and how leadership is reflective of the communities that they're working in. Great. Thank you, everyone, for listening to my talk about this. This has been a couple years worth of work that we're really proud of and really excited to get out there for people to be able to use. If you have any questions, you can find me after, or you can send me an email. Thank you.